Hi, I'm Mandy Horn. I am a women's health nurse practitioner and faculty here at TWU in the Women's Health Nurse Practitioner program. This lecture, we're going to talk about sexuality and sexual health. That's a lot of objectives, I know. So, sexual health is essential. We are sexual beings. We want to have sex. We like to have sex in general. So it's a key component to healthcare. It's a key component to health promotion, education. So the more comfortable you are talking about sex, the easier it's going to be to talk about sexual issues with your patients. Over time, patients will become very comfortable with you and they will start to tell you things about their lives, such as sexual concerns. And we want to make sure that you are prepared to understand what they're talking about and how you can help them and educate them. So, this is the definition of sexual health by the World Health Organization and by the American Sexual Health Organization. I'm just going to point out a couple things here that, just like I said earlier, and that number one, it's natural and it's normal. So a person's sexuality, as we know, doesn't necessarily have to do with their gender or the sex that they were born as. So sexuality is more than just sexual behavior. Recognizing that we all have sexual rights we share, even though they are maybe different between person to person. Education is key. Preventing unintended pregnancies and STIs is key. Communication is key. And being able to experience sexual pleasure, satisfaction, and intimacy when desired is part of sexual health. So if a person is talking to you about intimacy or sexual pleasure, if you have implicit bias about sex and how you're going to react to that conversation, you may not put that on your list of priorities, even though sex, sexual relations, intimacy, and communication are parts of being a human. So, just a brief overview: sex, gender, and sex orientation. I think the key is, luckily we are all more and more aware of the terms, even though some of the terms do change, or we add more terms, so they mean different things at different times. But the key here is that sex is based on the chromosomes and the genitalia, right? So it's generally assigned at birth. What do we see? There can be, and I'm sorry, I don't know how often that happens, but when we have the chromosomes and genitalia fall somewhere in between, and that's when, we used to, and probably still do in some places, just assign a gender based on what an infant looks most like. So when we say sex, we are talking about chromosomes, genitalia. Gender is a social construct, maybe based on the assignment at birth, or maybe by how the person chooses or feels to be. So social construct means that women are supposed to act like this and do these things. Males are supposed to act like this and do these things. And that's how traditional roles are attributed to different genders. So now, as the world is opening up a bit and realizing that those traditional roles don't have to fit in a box. Gender identity is a person's understanding of their gender. So that is how they identify their gender. And then sexual orientation is who they are attracted to in their behavior as a sexual being. So the biggest bias that we have as um, just people is that we have a biased view that when we say, "Are you having sex?" we assume somewhere in the back of our head that that means penis to vagina intercourse is sex, right? And so if we look back at studies on sexual health, wellness, behavior, all of those old studies are done on this model. So, sex is penis to vagina intercourse, and then all the questions that come from that regarding sexual health and behavior. So, sexual activities, that can be defined much more broadly, and you really need to listen to your patient. So, this is just, I even narrowed this down so it didn't, or it would have taken 3 pages. But sexuality or sexual behavior is across the board. So just because you see someone and you form a reaction to what you think you know who they are or what they're about, just know that you don't. So understanding some of these things about a person, you do have to get into these things sometimes. You know, that is at a comfort level and a certification level as far as what you are comfortable talking about. Some people would do better with a sex therapist. You just have to kind of dive in and see what's really going on. So, cultural norms, like we said a second ago, that our traditional or classic view of what sex and sexual intercourse is. And then based on the slide before, that there are a lot of variations on that. But the key points to any of those things is it consensual? Does it put the partner at risk? If so, how? And is that an acceptable risk to the person? Is anyone else at risk? And is she distressed about her desires? That one is the key. If she is distressed, then we need to figure out what is going on and help her. No matter what his or her choice of sexual activity, if it is consensual, it is not hurting anyone. No one else is at risk, and of course, we're talking consensual adult behavior. Then we just help from there. This is from the American Psychiatric Association. So basically, when it comes to consensual adult sexual behavior, we don't get to decide what's normal. The person and his or her partner or partners do. So this is worded a little strangely, but there, in the DSM-5, homosexuality and other sexual behaviors such as sadomasochism were called paraphilias, which is an abnormal desire or sexual perversion. Some forms of sadomasochism are still listed as a paraphilia, but homosexuality was on that list, which is until like the 70s, I think. I don't remember the year that it was removed from the DSM-5. And so we know that homosexuality is not a sexual perversion or deviation. It is still considered such in many cultures and communities. Practitioners of consensual BDSM or kink, there is no variation in psychological or sexual challenges related to those who don't engage in what we call, not, or just in mainstream dating. The both of these groups, although different, still marginalized, I would say, in the majority of cases, actually pride themselves on consent and honesty. So there's some very interesting information about honesty in the mainstream dating society as opposed to honesty in what some consider outside of the realm of normal. These are some other terms that you may hear. You may already have an assumed definition of what that is. Monogamy, the partners are exclusive, and the rules within that relationship may differ. In a monogamous relationship, when someone goes outside of that relationship, that's obviously non-monogamy. So that is infidelity, cheating, whatever word that you use. Some relationships are consensual non-monogamy. There are a couple of variations of that. Polyamory is like a family. So all persons involved know and they are consenting to the arrangement. It is not sexually or emotionally exclusive. The partners may have an emotional connection with one person, a sexual connection with another person, vice versa, both. But the key is that it is consensual, everyone knows. Another form of that is called ethical non-monogamy. But that basically means a person is not, they may be in a relationship, but the partner is aware that they are not monogamous, and those partners may not be involved with each other. So, but there should be honesty and openness so they can discuss pregnancy prevention if that's the case, safer sex practices. So that honesty and openness is very important. And your patient hopefully will feel like they can discuss these things for you if you have a very open mindset to them. So the term sexual desire is really the motivation to engage in sexual activity. It's very nuanced because there's really not a way to measure it because it's in your brain. So not every biology drives our reproductive desire, but not every sexual thought or desire is motivated by reproduction, right? So it's a feeling. So it's not well studied. It's not well defined. The best words we have right now are physical sensation, wanting, emotional craving, excitement, arousal. Again, because we can't study that, we don't have a way to say what is normal. Some misconceptions, some created by pharmaceutical companies, that you must experience desire to become aroused. That does not have to, it doesn't have to happen in a certain logical step pattern. So you can, men or women, or can be stimulated by lots of things and can be formed and can be altered by lots of factors. So, however, a person is brought up, right? So, parenting, the school they went to, religious rules that they were taught, social norms. So, what is acceptable or what is taboo? Another thing that can be interesting or uncomfortable is the traditional assigned at birth female. The traditional way that women were viewed were either as asexual, pure, perfect, or a temptress. And so this was part of the push for feminism is we were basically told that we had to be both of these things and at the same time. So that can be very confusing for anyone. So now, take that traditional thought process and put it into the world that we live in now with so many variations of desire and sexuality and gender. And it can get very confusing for people trying to figure out who they are and what they want and what they want to be. So we always have to think about trauma response, trauma conditioning when talking about sex. Um, when when she's presenting with a sexual concern, such as pain with intercourse or inability to have intercourse, or that she doesn't have any desire to, she has very negative feelings about sexual behavior. You always have to consider any form of trauma, abuse, mistreatment, intimate partner violence, because you can re-traumatize a person in a healthcare experience, because a healthcare experience is so intimate. That can trigger issues, especially if you become someone that the patient really trusts, and then you have to do a medical procedure and it's very painful, or if she has a difficult pregnancy or birth experience, lack of inclusiveness, any of those things can reactivate that trauma response. And that is obviously the very last thing that we want to do to anyone. It is very important that people have an awareness of their own sexuality, and lacking that information is actually very, very common. I have done this for many, many years, and so many women, young women, trans women, don't have enough information about their own body, their own sexuality, for many reasons. Most often, in my experience, it has been cultural upbringing and education. Either, parents were too nervous to have the discussion, or it was a religious choice to say, however they were educated or not educated. So, with that self knowledge, we actually empower the person. Um, let's say a woman is not educated well about sex, what it should be like, what it should feel like, what we expect that intimacy to be like, what we expect it to feel like physically. And she has painful intercourse the moment she gets married, and that never goes away. So, unfortunately, now she thinks this is normal. And because no one ever taught her that it should not be painful every time she has sex. So, those are the reasons one of the many reasons it makes me very sad that women are not better educated about their body, and that self exploration is okay and encouraged. And, um, you know, women need to be, made aware of when something is not enjoyable, how to communicate that to their partner. Just giving them that confidence to understand how things should be. So again, because of our social norms of acceptable behavior, your histories may or may not be complete or accurate. Again, that through their lens of what they think is appropriate. So collecting a very thorough sexual history and doing it in an organized, non-judgmental way and doing it in the same fashion every time, um, and expressing to the patient that you are there to help them and take the best care of them, um, is really, really key to figuring out what needs to be done for them. The patient doesn't feel comfortable enough to tell you that she has sex with men and women, and doesn't use condoms with men, or has just hookup culture sex but doesn't use condoms. She's going to automatically think you're going to judge her for both of those things, and she may not tell you either one of those. Those are things that you need to know. So just a brief rundown, that's our cute little clitoris there. The structure of the clitoris is there. Most women do not know what that looks like, but it does wrap around the entire vagina there. I don't want to get into that. So lots of medical factors can impact, sexuality. So you definitely want to address those. Say if you are diagnosing a woman with a patient with diabetes, you can certainly tell them how that may affect them. We do know that depression or medications can affect anyone's sexuality and desire. So you definitely want to discuss that with them. Adolescence, again, supporting young people as they move through those developmental tasks. Self esteem and body image is so difficult at that age anyway. So if they don't understand, they haven't been educated about what their body is doing and why it's doing it, and that it's normal, and that it's normal to feel these things and what the hormones are doing to their body, and that it's normal, and that everyone else is, going through the same process, then they can make better choices because they don't think it's something um, crazy happening that they don't have any control over. So that education before adolescence is very important. So, quote unquote, early sexual debut, which is the first intercourse, is defined as younger than 15. That's going to be very different in different cultures. So, virgin or virginity still has some sort of purity connotation to it. But you also have to keep in mind that to most people, that means I can be a virgin, but I've not had penile, vaginal, heterosexual sex. So I have had teenagers have penile anal intercourse so that they could still be a virgin. So those are where the questions and the words do become very important. So you need to understand those nuances and the terminology of the age group that you are speaking, who you're talking to, right? Changes of sexual desire during pregnancy. Most women feel horrible in that first trimester, so they're not interested in it at all. That second trimester, most women feel really great, and most do have an increased desire for sexual intercourse. Then the third trimester, some do, some don't. It's uncomfortable to be very, very pregnant, and some are concerned about hurting the baby. So, if you do have a pregnant patient who is asking you about intercourse, as long as there is not a medical condition that we have told them not to have intercourse, let's say they have a placental issue or a history of preterm labor, a reason that we have told them pelvic rest, no intercourse, they can safely have intercourse at any time during pregnancy. They're not going to hurt the baby, they're not going to hurt anything. Um, a lot of women do have body image concerns during pregnancy, which can, of course, affect our sexual drive, sexual response, pregnant or not. So it's sometimes that you need to provide some encouragement about their body and do a little counseling about how do they feel about it. So there's not a lot of study about sex in the postpartum period. We ask women to wait for 6 weeks before they return to sexual intercourse. 4 is probably okay, depending on the type of delivery they had. But based on the information that we have, about a little over 40% of heterosexual couples have resumed intercourse by 6 weeks. So there are physical concerns. Women, your body is definitely not what it was before a pregnancy, even 6 months after a baby is born. So definitely not immediately. Women are exhausted. Dads are exhausted. There are hormonal changes. The vagina is typically dry because of the hormones of postpartum and breastfeeding. There are lots of psychological concerns. You can have postpartum depression. You've got a transitioning role, whether you're going from being a working dad to a stay-at-home dad, or a working mom to stay-at-home mom, or from a stay-at-home mom to a working mom, from being an individual to now you have an extra person to take care of, or maybe you're adding another child, so now you're a mother with a newborn. Especially if you don't have a lot of help, it can become difficult. And typically you just have a loss of self after when a baby is born, because you are just dealing with, you're just trying to take care of the baby and sleep, and that's all you can do. There are also financial concerns in addition to the family work changes. So again, you need to have this conversation that all of these things are common and normal. And if she has these issues, or you want to talk about them then at the time, and I would definitely do this before she has her baby. So in that third trimester of pregnancy, this is when we should start discussing these things. That anticipatory guidance is crucial. We all do better if we know what to expect. In midlife, a lot of people think, oh, well, she's 50 or whatever. Actually, women in their 40s, 50s, and 60s have an increased interest in intimacy. The children are grown or gone, or they have found a new happy relationship. They have, maybe saved some money. They maybe are looking at retiring something. There are lots of changes during that midlife time. The way to keep the vagina tissue healthy actually is sexual activity. So as we decrease our estrogen, which is what starts to happen in the midlife, the vaginal tissue can become less pliable and it can become dry. So by using lubricants, sorry, not lubricants, moisturizers, and sexual activity, whether that is with a penis or with a toy or with a dilator, to keep the tissue pliable, that is the best way to do that. Older women, still sexual beings, healthy aging, nutrition, fitness, sexual satisfaction, just our general health and wellness